Yeah, thank you. Yeah, my name's Jen Brownbridge. I'm going to attempt to build on what Artie and Mike have put forward and run you through the children and young people element of these formularies. So I think I won't labour too much, but I think Mike and Artie have set the scene really well about asthma being our most long-term condition, most common long-term condition, and that is reflected in the child and young people population as well. And it's really well documented and known about that we have some of the worst outcomes in Europe, and in our population for children and young people, outcomes tend to be worse, and there are more preventable deaths in that population, and under sort of more deprived community children, younger people that come from more deprived backgrounds are at more significant risk. So the National Bundle of Care for Children and Young People with Asthma was published in 2021 by NHS England, which is a blueprint of evidence-based interventions to help children and young people, their families and carers, to control and reduce the risk of asthma attacks and prevent avoidable harm. And there are 7 components to that bundle, but the new Humber North Yorkshire Children and Young People's Asthma Guidelines seek to support in the delivery of the standard for effective preventative medicine. And the guidelines are largely based on recommendations from the most common national guidelines that we have available to us, so BTS, NICE and GINA. Chronic management is the most crucial aspect of asthma treatment, and if done correctly, a child or young person can live unrestricted by their asthma without the need for emergency treatment. So the overarching aims of the guideline ultimately is to improve outcomes and quality of life, but paramount to achieving this is clinicians selecting the correct drug, the right dose, and delivered in the most appropriate way for the patient. So the guidelines do pay attention to the need to reduce the environmental impacts that Artie mentioned with the greener agenda and net zero ambitions. In the same way as the adult guideline, you'll see throughout the guidelines a little green leaf, which signifies the treatments that have a lower carbon footprint. However, I would strongly recommend that the greenest inhaler is the one the patient can and will use. And it also pays attention to supporting a cost-effective prescribing as well. So as you can see here, this is the first page of the 6 to 11 year asthma guideline. You'll see it's set out in a similar way to BTS and GINA with a stepwise approach, and the dosages are based on paediatric ICS potencies, starting with very low dose ICS as the regular preventer, stepping up to an initial add-on therapy of either low dose ICS and montelukast. With a quick note on montelukast, if this is used as your initial add-on therapy in children and people, we recommend that it is done for 4 weeks and as a trial, and if there's no benefit seen, then that should be stopped. And it is really vitally important that we counsel parents on the potential side effects that can be seen with montelukast in some patients. There is more information on that on the MRHA advice on the gov.uk website, which I can put in the chat at the end if anyone hasn't seen that. And then the final step would be additional controller therapies of ICS LABA. The box up in the right is just a general box on the principles of good asthma care, which should be considered before we step up and step down any treatment. And crucially, when a change has been made, we should ensure that a review has been arranged within an appropriate time frame. As previously mentioned, the green leaf signifies them lower carbon options. And in this guideline, you will notice that there are 2 PMDI options in the first step that have the green leaf by them. And the reason for this is that where appropriate and where possible in the younger populations, you can optimise your prescribing with a higher strength formulation but lower puffs to deliver the dose. So for example, the most common first step for children and young people starting on a preventer is clenilmodulite 50 micrograms, 2 puffs twice a day. You can optimise that to clenilmodulite 100 micrograms, 1 puff twice a day, therefore reducing the number of puffs and overall carbon footprint of that prescription. The greyed out options are the DPI options. They are greyed out because generally we advise they are introduced in the over 12 age group, which is reflected on the next guideline I'm going to show you. But the DPIs on this formulary are licensed in children and young people over the age of 6 years. And on a case-by-case basis, we would recommend that DPIs can be considered, but only after a face-to-face consultation and after really good education and observation of inhaler technique. And that really can't be understated, that, you know, if you're sending a patient home with a prescription that they don't know how to use, their asthma control will likely worsen, and there are examples of children that have ended up in hospital after mass switching from PMDIs to DPIs. So we would just advise that if you are going to do that, it's done in a controlled way after a shared decision-making process, and a follow-up is arranged within an appropriate time frame. And finally, on this page, you'll see a box in at the bottom when to refer to secondary care and some additional considerations. But in the interest of time, I will not read through these, but I am happy to take questions either at the end of this or via email. But these are based on guidelines, national guidelines of when we should be referring in to secondary care. The next slide of the 6 to 11 is just some further prescribing advice in relation to spacers and relievers. As Artie mentioned at the beginning, a spacer device is recommended with PMDI devices, and certainly in children and young people, it tends to be the first step and first treatment option for children and young people, PMDI plus spacer. In this age range, we recommend that a mouthpiece is used over a face mask, with the exception of children and young people who have difficulty coordinating a mouthpiece. But generally from around 4 to 5 years old, a child can, after, again, good training and education, move over from a face mask to a mouthpiece. There are some general spacer tips around the spacer devices and caring for them that you can highlight to your patients. And also just a note that it's quite common that families will ask for a second device and spacer, and this is generally for school and is very much appropriate, so that a child has access to their treatment in school and at home. In terms of relievers in this age bracket, the choice tends to be is recommended as a PMDI plus spacer of salbutamol, and again you'll see that the green leaf is there. That is not that is to signify that salamol is the preferred choice for reliever therapy in this for the PMDI in this formulary, and this is due to its lower carbon footprint over other brands. The remaining box are some points on the overall aims of treatment, stepping down of treatment where asthma control allows, and some final points on air quality impacts and considerations in this age group. This is the 12 to 17 year formulary guideline, and this guideline is largely based on GINA and includes the addition of air, and there was an aim when producing this that we mirrored that of the adult guideline, and this is really to allow a really seamless transition from childhood into the adulthood pathways. So it is set out in the 2 tracts as was in the adult formulary that Mike presented, and the green track is the preferred option. However, we recognise that in this age group, children and young people may already be established on a fixed dose regime, and they may not wish to switch to the asthma track, and indeed may not wish to go from a PMDI device to a DPI. And again, I would stress that the appropriate treatment is the one the patient can and will use. The green box between the 2 tracks is just some pointers on when to consider switching or changing treatments, but in all cases adjusting treatment should be done following a shared decision-making process with the child, young person, their family, and with face-to-face observation, education of inhaler technique and follow-up. An important consideration in this age group when choosing the best treatment is whether the child or young person will use the spacer plus a PMDI. It's often not practicable as they get older to carry a spacer and an inhaler, and often causes embarrassment around their peers. So in this case, it may be that after you've had a discussion with that patient, they may wish to switch to MAT and air, and I would recommend using that tool that Artie showed at the beginning, helping that decision-making process. But it's important to have open conversations with the child or young person and really try to understand their thoughts and feelings around their treatment and what barriers there are. You know, if they have a chaotic lifestyle for whatever reason, that really does affect their ability to take preventive treatment. So it might be that an anti-inflammatory reliever therapy or MAT therapy is a preferred option for them. This page, again, similarly to the 6 to 11 guideline, just includes some tips and hints on spacer devices and management gold standard or good asthma care principles. And again, in this age range, if you're using a PMDI, a spacer must be used, and it must, where possible, use a mouthpiece rather than a mask. And then the final page of this one, again, we have some sort of tips on treatment aims, stepping down and air quality, but I just want to pay attention to the MAT tips. This is similar to what was on the adult guideline around MAT. but more specific to children and young people. I think the main difference in this age range with MAT is the instruction that we give to co-prescribe a SABA and spacer for emergency use, which really does sort of go against the principles of what we're trying to achieve with MAT and air therapy. However, the reason we've gone back and forth with this with various colleagues across the country actually, and our tertiary care colleagues, and the reason that we've opted to keep this on there is that most children in school will have access to an emergency inhaler and spacer, and this will be the first line that schools use in an emergency, and often schools will ask families to provide a blue inhaler and spacer for school as well. So therefore it's there because that to reflect that really, but we should be promoting self-management skills as young as possible with asthma, and a child or young person who is at high school, who is walking around school with their inhaler in their pocket, they will be able to follow a MAT personalised asthma action plan, which we are going to QR code on there for a resource as well. And then finally on this page, there is just similar to the adult guideline, there's some further resources. So one of them will be to Asthma Lung UK, which Artie demonstrated earlier, has some really good videos on inhaler techniques, which really can support your consultations on inhaler technique. And then finally, there's the Healthier Together QR code. This is the Humber North Yorkshire Healthier Together site, and it has pages for healthcare professionals to access with regards to information around common health conditions in children and young people, and treatment options and resources. But it's primarily a resource for children, young people, parents and carers to seek support and advice regarding common health conditions, and that includes asthma. And then just finally from me, anyone who cares for children and young people should have the correct knowledge and skills. NHS England, as part of the bundle of care for asthma, have endorsed a tiered training approach. There's 5 tiers. The QR code on screen is for tier 3, which is aimed at clinicians who are responsible for prescribing and reviewing asthma in children and young people. It's a course that is free, and it is accessed through e-learning for healthcare. Takes approximately 7.5 hours, but you can chunk it up and do it at your own pace, and I really would recommend it. It's a really good resource to support you in managing children and people's asthma. And that's it from me. I've put my email address on there if there is anything that you wish to ask me via email, but I'm happy to take any questions at the end. Thank you.